Доктор Станков, доктор Добричков, професор Велчев, доцент Велчев не го видях. Окей. Floor is yours. Микрофон може би за панелистите ще ни трябват. Окей. Успех на всички. Good luck.
Liver and visceral endovascular procedures, and for the sake of time, I have the pleasure to invite Dr. Tsvetanov to have his presentation on POCUS assessment of acute gut ischemia.
Good morning to everyone. Very nice to see you in this sunny Sofia morning. So as a beginning of the session, we are going to start, of course, with the pathology, the pathophysiology of acute ischemia, and how can we use ultrasound for acute gut assessment, ischemia assessment. So about the definition of the problem, the acute mesenteric ischemia is a life-threatening condition which is caused by sudden interruption of the blood supply of the intestines, which of course leads to very big cellular damage, necrosis of the intestines, and of course in up to 50% of the patients it leads to death. Acute mesenteric ischemia could be occlusive or non-occlusive disease with primary etiology further defined as embolism in 50% of the cases, acute mesenteric arterial thrombosis up to 25% of the cases, and of course venous thrombosis. So the overall incidence, it's low, up to 0.2% of all patients with acute problems admitted to emergency rooms, and the patients are representing with abdominal pain, but the acute ischemia, it's a common cause of emergent intestinal resection. As I said, the mortality exceeds 50%. So about the guidelines, we have two guidelines which we have to be aware of. This is the updated guideline of the World Society of Emergency Surgery for acute mesenteric ischemia, and of course the guideline of the European Society of Vascular Surgery, management of the disease of mesenteric arteries and veins. About the pathophysiology and epidemiology, the acute mesenteric arterial embolism, which is up to 50%, occurs due to mesenteric emboli, which can come from the heart, the left atrium or left ventricle in different conditions. Of course, sometimes emboli can be generated from the wall of the aorta if we have atherosclerosis. Emboli typically lodge at the points of normal anatomic artery narrowing, of course, and the majority of emboli are lodged 3 to 10 centimeters distal to the origin of the SMA. That's why we have problems in the proximal ileum and colon. In 20% of the cases with SMA emboli, we have also emboli in the spleen and kidneys. So about the acute mesenteric arterial thrombosis, it's up to 20% of the cases. We usually have pre-existing atherosclerotic disease in the patient. We have history of postprandial pain, weight loss, or even food fear. Thrombosis usually occurs at the origin of visceral arteries. SMA thrombosis can be found also in cases with vasculitis or mesenteric dissection or mycotic aneurysms. About the non-occlusive mesenteric ischemia, it's usually a consequence of SMA vasoconstriction in other severe coexisting illnesses of the body. The venous thrombosis, it's usually in young patients without obvious cause. If we have some inflammatory process around the superior mesenteric vein, if you have status of hypercoagulability or thrombophilia due to malignancies or some hematological diseases, or if the patient takes contraceptives. So this is the risk factors which are specific for different types of acute mesenteric ischemia. How do we manage patients with acute mesenteric ischemia? Of course, the goal is to keep the time to reperfusion as short as it is possible. The guidelines, they recommend dedicated centers. They are called intestine stroke centers. They have such centers in France and China, which use multidisciplinary approach to improve outcomes. The multidisciplinary team contains general surgeon, vascular surgeon, interventional radiologist, of course, anesthesiologist, and probably angiologist. So we have a triad of symptoms which is very common in patients with acute ischemia. This is the historic of embolic incident, severe peri-umbilical pain, which is out of proportion. We have also vomiting and diarrhea. These are the usual risk factors for different kind of ischemia. We have to be careful with venous thrombosis because the damage is usually in younger patients with mild symptoms. What do we use traditionally for diagnosis? We usually use CT angiography, MRI angiography, endoscopy. These kind of methods will be discussed later in this session. So what is POCUS? POCUS, the term means point of care ultrasound, which refers to a portable ultrasound systems that can allow us to assess patients in the emergency room without taking them to the radiology department. So we can say that POCUS covers portable ultrasound devices used in the diagnostic process to address specific pathological hypotheses at the bedside of the patients in the emergency room or even in the ambulance. So the benefits are that this method is rapid and non-invasive. It's available at the bedside, can be performed by clinicians with basic ultrasound training, and it provides a real-time feedback for clinical decision-making. So what are the key ultrasound findings in acute gut ischemia? We have three types of findings. The first group is findings from the bowel. We have bowel wall edema. The wall is with increased thickness, more than 4 millimeters. Due to the fluid accumulation, we have hyperechoic appearance of the bowel wall. The second group is ultrasound findings in the mesenteric artery. We have reduced or even absent flow in the affected vessels. We have different kind of Doppler velocity changes. If we have stenosis more than 70%, we have peak systolic velocity more than 2075 centimeters per second, or even high end-diastolic velocity. The third group of findings is free fluid in the abdomen. So this is the normal view with B mode of the celiac artery, SMA, and the aorta. This is how it should look if we have normal vessels in each artery. So this is the normal ultrasound testing of the SMA with normal Doppler velocities, and a case with high stenosis with peak systolic velocity more than 3,000 and diastolic velocity more than 80 centimeters per second. About the bowel wall edema, this is how it looks from the left and the right. So the ultrasound protocol for assessment of acute intestinal ischemia includes three points. We have to examine the bowel, of course, to scan from the epigastric area to the pelvis, use both transverse and longitudinal views. We have to evaluate the thickness of the bowel wall, the echogenicity, and other signs of gas in the intestines. We have to assess the mesenteric arteries, SMA, the celiac artery, IMA if it is possible, and we have to evaluate the peritoneal cavity for signs of free fluid. This should be done in more than 5 minutes. So what are the limitations of POCUS in acute ischemia? Of course, it depends on the operator's experience. We have also limited sensitivity, and there is some difficulty assessing severe cases. We have to make as fast as it is possible CTA. So this is what the guideline says. Duplex ultrasound is not an appropriate imaging method to assess acute occlusive lesions of the visceral arteries. And the guideline says also that CTA should be performed without any delay. So the treatment options, they are open surgery and different endovascular techniques. They will be discussed also in this session later. So this is a usual case example. Of course, a patient with severe abdominal pain, hypotension, with risk factors for mesenteric ischemia. What we find with using ultrasound: thickened small bowel loops, absence of blood flow in the mesenteric arteries. We have some pictures. This is the small bowel loops. And of course, the absence of blood flow in the mesenteric artery. So the diagnosis is acute ischemia. We have to make emergent surgical consultation. As a conclusion, acute mesenteric ischemia is a serious surgical emergency. The most important message is to have a high index of suspicious, which is based on the combination of history of the patient. So POCUS is a valuable tool for the rapid and early detection of acute ischemia, especially in the emergency settings. Immediate assessment with ultrasound can assist in clinical decision-making, potentially saving lives, but there are some limitations, of course. The evaluation and treatment of patients with acute ischemia by an interdisciplinary team is in especially dedicated centers improves outcomes. So this is another recommendation from the guidelines. Every patient with severe abdominal pain out of proportion to physical examination should be assumed to be acute ischemia. The future directions, of course, the improvement in imaging technologies by using enhanced contrast ultrasound or elastography could improve sensitivity of the method. We have to train and educate some specialists in this kind of exam. Also, we have to integrate other modalities like CT or MRI so that we can save lives. Thank you for your attention.
Any questions from the audience? Thank you. No? I have just one question for you. How often do you think you have false negative results on the ultrasound comparing to CT?
So I'm an angiologist. So sometimes it's very difficult to assess the blood vessels in the abdomen, even the patient doesn't have ischemia. So in patients with symptoms of acute ischemia, probably we can make mistake in more than 80% of the cases. So that's the reason why the guideline says that you have your 5 minutes to make the exam, but if you are not sure, you have to make CT. So the percent of problem is very, very big.
So the ultrasound doesn't rule out the CT scan.
Of course.
Perfect. Thank you. Please join us.